Welcome to another edition of Going the Distance with Go Long. I am Jill Consor Beck, founder of Go Long. And in Going the Distance with Go Long, we bring conversations with experts on topics that are very pertinent to women 40 plus, women who are in the sandwich generation. And Go Long is an accountability coaching service, but the difference is that we do our accountability coaching via text so that this way it doesn't interfere with your life. You don't need another meeting on your calendar when you're already oversubscribed. So with that, I want to introduce Dr. Rachel Gerson. And Rachel and I actually met a long time ago. We were on the same triathlon team way back in the day when I was doing distance running. And then we reconnected on a joint angel investing venture last year. And it was great because I had already started the show and we were talking about what I'm doing at Go Long. And she's a radiologist. And I think there's a lot of misunderstandings about what radiologists do and don't do. So we're going to talk about that today. And just to give everyone a heads up that we're going to do a separate show just on breast cancer. So we're going to touch upon it a little bit today, but we're going to get into a lot of specifics about breast cancer in a separate episode because there's so much to cover there. So Rachel, welcome to the show.
Thank you. Thanks for inviting me here. I'm excited to be here.
So tell us, like, how'd you get into radiology? Like, let's get into your story.
Yeah. Well, I after college, I actually studied education, and part of why I did is because I had been super interested in science as when I was in college, but you didn't get to talk a lot in big science lecture classes, and I thought, I want to be more interactive, and there ought to be a better way to engage people like me in science. So I got into actually science education for a while and taught for a little bit and did some curriculum development around science education. And then ultimately decided that medicine was kind of the place where that sort of human interaction and communication piece linked up with science. So I ended up going to medical school and kind of surprised myself by really falling in love with radiology. And I looked into a bunch of different fields, obstetrics and gynecology, ophthalmology, or a bunch of different things. But radiology, super visual, which I didn't realize was actually one of my skill sets, but it continues to be. My kids will tease me because I'm always scouring photos of them at camp. I see a little bit of your curls, that must be you. It's like a detective. It's kind of like, where's Waldo? I really like anatomy. And the radiologist, what we often say is the radiologist is the doctor's doctor. So, and this has become more and more true over time, is very few people make it through the healthcare system without interacting with radiology, right? And we provide data and information that helps the clinical team put together a full picture of what's going on with the patient. And that's one of the things I really like about it is, although we don't learn as much in depth about one specific area, we learn a lot about a wide variety of diseases and disease processes. And we see almost every patient in the hospital at some point. So I like that interaction, that consultative aspect. I interact with clinicians all the time, helping them make appropriate choices for the best care for their patients.
Yeah, I was going to say, as you were talking, that you are the ultimate generalist, maybe like another generalist, like an ER doctor, where you interact with everybody. And I guess one of the upsides of being a radiologist is that you can't get bored because you deal with every specialty out there.
Yeah, that's
that fair?
really true. Yeah, I mean, that's certainly true of our training, and that's true of how I practice. I have subspecialty training in musculoskeletal, and I do a lot of breast and women's imaging, but I also practice as a general radiologist. Certainly some people, you can specialize and be just a breast imager or just a body imager over time, but all of us are trained as generalists, and that's really true. We're required to really understand a broad variety of topics and how they interact. Like you might see something we'll talk more about this on our breast day, but for example, in mammography, um, we're looking for breast cancer. That's what we're doing. But we also end up getting involved in diagnosing lymphoma or even cardiovascular risk. We're learning more about how uh, uh, arterial calcifications that we see in mammography can be an indicator of increased risk of cardiovascular disease in women, those kinds of things. So your brain is always having to link to what else could this tell me about uh, the health of the patient.
That's actually an interesting tidbit because, you're reading a lot more about how women are much more susceptible to cardiac disease and heart disease. So having that, most women may not be going in to like get, doing like a stress test or an EKG, but a lot of women do go in for their annual mammography, right? And
For
so,
sure. And in fact, cardiovascular disease kills more women than breast cancer. But
right.
breast cancer is a much scarier diagnosis. And uh, for many reasons, obviously. But yeah, so it's an important, we often forget about the importance of that kind of screening. And it's interesting. We're learning more and more about how there actually, this is an interesting area in radiology in general as we move into the world of artificial intelligence and new data is the idea of opportunistic screening and what data is on the image that can tell us about things other than the question we're trying to answer right at that time. And for example, uh, uh, arterial calcifications in the breast is one example of that. But that there are opportunities to think about prevention, to think about general health that go beyond trying to answer the specific acute problem with imaging. And there's really a ton of potential there.
Yeah, I can see that. I mean, because then you're thinking about stroke prevention as well. All
Exactly.
of those things. There's a lot of linkage between that, and obviously, strokes can be incredibly devastating. In terms of the impact and especially how quick you catch them. So, what I want to start with is I mean, you talked a bit about you're a generalist and why you were attracted to that as your area of expertise. But maybe we could talk about most people, I think, deal with a radiology tech when they go in and they get their scan. And the radiologist is generally like behind the scenes, like looking at that. So maybe you could talk a little bit about what happens. The patient goes in, they get the test ordered, whatever that is, right? That requires a radiologist. But there's generally that radiology tech that is working the machine, right?
Yeah, so I think it's important and this is not everyone knows this, so I think it's important to be clear. So radiologists go to medical school; they're MDs or DOs sometimes, but they go to medical school. They're
What's a
licensed
DO just for some people who may not know?
doctor of osteopathy,
Okay.
um, uh, uh, and really, in terms of our practice, ultimately those end up being equivalent. They have a slightly more holistic. Curriculum in their medical training, and I'm not as familiar with that, so I can't really speak to it. But for all intents and purposes, in practice, we're equivalent. Um, yeah, so MDs and DOs, licensed physicians, and so radiologists are physicians, and we interpret all kinds of medical imaging from ultrasound to mammography to CT, X-ray, MRI, nuclear medicine studies. There's a wide range. And there's also interventional radiologists who treat disease with catheters. We uh, do biopsies, needle guided procedures, administration of radiopharmaceuticals to treat cancers like thyroid cancer. So there's a wide spectrum of skills that we perform. And again, some people are more general, some more subspecialized. And when you're a patient, though, it is true when you come into the hospital, the actual obtaining of the images is most often done by a technologist of some sort, whether that's a radiology technologist taking x rays or with special training for CT or MRI. Ultrasound technologists have a different training path, but they often perform the ultrasound. And then all of those images get reviewed by a radiologist. Sometimes you may never see the radiologist, sometimes the radiologist may come in to talk to you, particularly in mammography and breast imaging. There's tends to be a lot more interaction with the radiologist. I see probably uh, between 2 and 6 patients a day when I'm at the hospital, either doing a procedure, answering a question, explaining a result, those kinds of things. And I would say there's, depending on the setting in which you practice, there are a variety of settings in which radiologists practice. There's a lot of teleradiology where the radiologist may be off-site. I am typically in person, but there's also a movement to sort of decrease that barrier a little bit so that if you have questions about your radiology results or report, that there's more of an opportunity to interact with the radiologist to understand those results. Sometimes that's filtered through the clinician that's ordered the study, and we certainly have a lot of contact and communication with the ordering physicians as well.
Interesting. So one time when I had my first hip, I was having some pain and I got the results before my clinician had a chance to look at them. And I didn't, I saw all these words. Of course, I didn't know. And I'm like, I just saw severe and extensive. And I'm like, those are words you don't want to see in a medical report. I just like deduced that. And so I texted the text to my neighbor who's an ER doc and a former PT of mine and my cousin in New York who's a critical care doc. And they all independently, and they all came back and they're like, you're having a hip replacement. And I'm like, what the fuck? Right?
Right.
That was not on my bingo card in terms of scenarios. And so it's interesting sometimes when it gets to you. I mean, that's the upside. You have that transparency. You have my chart or, whatever it is that Epic, whatever. And then you get it and you're just like, whoa, okay.
Right. And to be perfectly honest, that's traditionally the radiology report was intended to be a communication tool with other doctors and not with patients. And that's a shift now that it's a shift in thinking and philosophy now that patients have immediate access. I think it's for the best.
I do too.
I think it's a positive shift. But and what's interesting is we haven't fully caught up to this yet, but I think this is an area of interest for me. I do some work in the health innovation space and thinking about what a radiology report of the future might look like. There are efforts underway to try and, that your report might be immediately translatable into patient-friendly language, or might be immediately translatable into the language that you speak. For if you're not a native English speaker, for example, those kinds of things. And there are new tools arising where you might be able to click on a word that because medical jargon is it's not understandable. It's like another language. I remember that even from my first year of medical school, I was in an era where we still took notes by hand. And I go back and look at them sometimes, and I've written everything out phonetically because I didn't know what any of the words meant. So as a patient, often these reports are unintelligible. And I think there's some real potential in the future for using new technologies to make those reports more accessible
I
to
want to talk
patients.
about that later on in the show because I want to, I've been using AI, but I want to hear what your take is on someone who seems to be very pro AI in terms of the upsides of it, and obviously being aware of some of the potential pitfalls. So, what is it that when you're going in for a test, like if I'm coming in and you and I are just having a cup of coffee or a glass of wine or something, and I say I had this scan, and you're just like, darn, I wish you would have known that you could have asked for blah, right? People don't think that they can probably advocate for themselves when they're going in and getting some kind of scan that's going to be reviewed by a radiologist. Where is there an opportunity for people to advocate for themselves to make it less invasive, less uncomfortable, or, something like that? Is there that opportunity?
That's an interesting question. I think there is. I think one thing is to, and it's a challenge, right? When we go to the doctor, especially when we are having a problem, right? We're feeling vulnerable anyway. Having the responsibility to sort of know all the questions to ask or how to push back or that's a lot, right? So it's often easier to just take the recommendation and go with it. I think that one of the challenges is this imaging appropriate? Is it necessary? Is it going to change the management of my process? I think in general, most in our society, most people are inclined to want more information, but more information is not always helpful. Sometimes it just adds to anxiety and fear, or it finds things we didn't know were there that probably are nothing, but then lead to further testing, right? So there's issues around that. Um, Sometimes the study that we're getting is maybe not the best test, and I think that's something that has evolved over time through kind of the pressures in the healthcare system for efficiency and speed. That um, sometimes just a test just gets ordered because it's easier to order it than to consult with the radiologist to find out, is this really the best tailored test, um, or is it going to answer the question needed? Some things are more clear cut, other things less so. So one opportunity is just to ask about the test you're getting. What does the doctor anticipate it's going to tell them? How is that going to be useful? So that's one thing you can do. I think also when you come in and speak to the technologist, speaking up about your own comfort. I mean, even on the physician side, I've had to learn that, like when I'm doing a procedure, no, I'm not going to do the procedure until the patient is at the height I need it to be, the equipment is where I need it to be, that I've rearranged so that can be comfortable and the patient can be comfortable. It takes some learning to realize that those things are important. Do you have what you need to be comfortable? Do you have what you need to not be too nervous? Do you need something to calm your nerves before you come in, which
Right.
usually you have to get from your primary care doctor, not from your radiologist. But, it's important to think about that ahead of time. Um, are you going to have to not eat before the study? Well, if I'm going to have to not eat after midnight, maybe I want to schedule the study first thing in the morning so that if you're going to get a coffee headache, or you're not going to be able, or you're going to be hangry by 2 p.m. Those kinds of things, asking questions. Ideally, when you go to schedule a test, they tell you what sort of prep you need to do. You need to drink a certain amount of water, or you need to come in early to drink a contrast material or something like that. But it's important to ask those questions, like, what do I need to do to prepare for this test? Is there an optimum time to schedule the test given those things that you need to do to prepare? Am I going to need to have an IV? Is that going to involve a needle? Um, are you someone who's nervous? Is a family member going to be able to be in the room with me for many kinds of tests they can't be because of radiation exposure, but for some they can? Or is there going to be an extra person? For example, if you're coming in for a biopsy, is there going to be someone in the department who can be there to distract me if I'm nervous, or hold my hand, or those kinds of things? So I think that's important to understand as well. Do you need a support person? How are they going to be able to be available to you if you do those sorts of things? What should I wear to be comfortable?
So when you were talking about this, I was thinking, obviously, prep. The first thing that, if you're a person of a certain age, you've had a colonoscopy.
Mhm.
And I mean, that is some extensive prep.
Indeed.
And they've tried to, make it less so. I mean, there's now things where it's not as onerous, but it's still
Pretty
onerous. Yeah. Now, but you tend to get those results pretty quickly. So is there just a radiologist that just like hangs out there, because the procedure is so quick?
Okay, so this is an important distinction. So I'm glad you brought it up. So a colonoscopy is done by a GI doctor, a gastroenterologist, and they read those studies as well. That's not considered a radiology study. They
Oh,
use a
okay.
scope, and they are interpreting it as they're looking in real time. So a radiologist is not involved in that test, and they tell you when you wake up, what they saw or didn't see, and as well as providing a printed report. Now uh, there are alternatives to colonoscopy. And I think that's another important thing to bring up. You said, if you're of a certain age, most of us have had a colonoscopy. That's true within a segment of the population, right? So there are not enough gastroenterologists to provide colonoscopies to all the people who are eligible for colonoscopy. And I think it's important to point out as well that the recommendation for for initial colonoscopy used to be at age 50, and it's now at age 45 because of increasing incidence of colon cancer. So that's important to know. But there are other screening tools that are used and that are necessary precisely because colonoscopy is not available to everyone. You may not have health insurance. You may live too far away. You may not be able to get an appointment because there are not enough GI doctors. So there's stool-based tests. One is called the FIT test, fecal immuno. Oh, I'm going to forget the full name, but the FIT test.
We'll link to it in the show notes.
And there's also tests for DNA within a stool that these are looking for blood or DNA or other markers that could be associated with cancer. And those tests are actually quite good. They're much less expensive. They're readily available. They're non-invasive. They require no prep. Okay, they're not the gold standard. If they're positive, then you need a colonoscopy. But they can be helpful for screening if you're not able to get a colonoscopy, and those are done through your primary care provider. And then the other
I think Cologuard is one.
Yeah, that's one of the DNA tests where they test the stool for DNA markers that might be of cancer. They do have false positives as well. So just because it's positive doesn't mean you have colon cancer, but it would lead you to then be sent for a colonoscopy and kind of bump your access to a colonoscopy. Colonoscopy remains the gold standard. But the other option, and this is a radiology test, is a CT colonography. So it's basically like a colonoscopy, only we use a CT scanner instead of a scope. You do have to still do the onerous prep, unfortunately. But there's less sedation involved, and there's no scope put into your colon. So that we do administer air into the colon through your rectum in order to expand it, because the colon is normally sort of collapsed or full of, once you've had the prep, hopefully it has no stool in it anymore, but it is, then the walls of it's like a tube that collapses. So we use air to blow it up, so that you can look at all the walls of the colon. And then we do a CT scan, just like a regular CT scan, only now the colon is blown up like a balloon and we can see the inner contour of it really well. And similarly in that instance, so those can be more accessible to people as well. And we can look for polyps and things. And if that test is positive, then again, you need to go for a colonoscopy. The advantage that colonoscopy has is that if the doctor sees a polyp or something there, they can sample it right then and send it to the pathologist. But as a purely screening test, CT colonography is another option that has good results. And it makes the screening more accessible to people.
Okay, that's helpful. So when another topic that's been in the news, and I don't want to make this too political, is prostate cancer, right? And the guidelines in terms of when screening stops, and what I guess I've heard, because I have a family member who has prostate cancer, is that most men, it seems like, get some form of prostate cancer as they get older. And I'm waiting for you, and if you want to correct me, please correct me. But it's something to that effect. And sometimes, like, most of the time you hear cancer, you're like, oh shit, we got to treat that. But I've heard, and this was through my family member, that there's some forms of prostate cancer that treating it is not worth the downside, depending on how old you are and everything else. And so maybe you can shed a little bit of light on that if radiologists are involved in those scans, et cetera.
Right. So I would say that in general, this is not my area of expertise, although what you have said is true. And radiologists are involved in prostate cancer more often in evaluation. We do a lot of prostate MRI for patients who are known to have prostate cancer or if might require a biopsy, those kinds of things. But it's not really my area of expertise. So I'll probably leave that there, but it is
Okay.
true. And I think this is an issue with screening in general, right? Is there in general, it is true that finding things early tends to be better, right? But there are certainly some forms of cancer or early forms of changes that may lead to cancer that we don't know that they're ever going to turn into anything. So sometimes we end up kind of over treating. And particularly in the case of prostate cancer, that can lead to some significant morbidity treating prostate cancer particularly in older men that may outlive any risk that they would have from that cancer itself, and yet they suffer significant morbidity from having treatment. So that's always a risk in any cancer screening: is does the treatment outweigh
Is
the
it
benefit,
right?
right?
Is it really going to give you that outcome? Is it worth the downside? Right? Is the
Right.
upside worth the downside?
Right. Are we finding something that's so small that was never going to turn into anything before you die of other causes or something like that?
Yeah, and I guess that's where, and again, we'll get into is like how AI can help, in terms of studying that and like studying the probabilities of certain size, certain type. I mean, I go to my dermatologist every year, but one year, and it was just as COVID was ending, I felt something that I hadn't felt on my forehead. And so I went in and I'm like, hey, I don't know about this. And she looked at it immediately. And I mean, to be able to, if you're able to categorize what a dermatologist sees, that you can just take all of that's in her brain. She immediately looked at it. She's like, I don't like that one.
Yeah.
And sure enough, it was not good. But
Right.
fortunately, I caught it early enough and it was first layer of Mohs. It was done, gone, great. But, when you're thinking about taking that knowledge and all of these experts, all these medical professionals, they're experts, and putting that into some kind of model so that you could sit there and analyze, like, yeah, the likelihood of this becoming bigger or the likelihood of that being mostly a nothing burger, right? That has the opportunity to also save the system a lot of money.
Right.
But not
Absolutely.
in like a bad way where we're taking care away from people, but we're saying like, look, this country has so many people who are drowning in medical debt. Right? Like, is there a way where you can do something that's less invasive to kind of keep an eye on it? And once we know it reaches a certain threshold, then we get in the big guns.
Right. And I think that's a really interesting potential of artificial intelligence. So it's not only identifying, what is going to turn into something, but also there's a lot of new potential around risk stratification and saying, for example, there's a newly cleared AI, just brand newly cleared AI tool in breast imaging that is about not saying that you have cancer, but saying that your 5-year risk based on your mammogram of getting cancer is higher. So you need to be screened more carefully. And I think that's really the goal, is to be able to personalize recommendations, right? So we have a bunch of screening recommendations, like lowering the age of colonoscopy to 45, or starting breast cancer screening at 40. And the goal of those is to standardize care for people so that people don't fall through the cracks, and so that treatment and screening is not based on anecdotal experience, like, oh, I think you'll be fine, or, I saw someone just like you who, and therefore I think you need more screening, right? We don't want it to be anecdotal. So we set standards based on evidence-based guidelines for populations. But I think the goal is to be able to say, no, this person requires more screening and this person doesn't need screening as often, so that instead of everybody getting more and more and more, that we have really personalized and targeted care. And that's kind of the promise of AI. We're not there yet, but there's a lot of really exciting developments in that area. And I think there's a lot of potential. And that's what those of us who think that this field and what it means for radiology is exciting, really are excited about that piece of it, that it's promise of sort of really personalized healthcare.
Yeah, and I mean, even as a consumer, I would be excited about that because, look, we both, I don't know if you still do endurance stuff, but my endurance days are over, with now bionic hips. But the thing is that being able to like tie in your heart rate with some other metrics, right, would be fantastic. And if you think about someone who is like a type 1 diabetic, being able to like kind of triangulate their blood sugar along with their heart rate and everything else to figure out like if something is going to happen like catastrophic,
Right.
and being able to have that kind of predictive type of data so that
Yeah.
you know that like, oh, this is bad, and someone may get an alert, like your partner may get an alert, your doctor may get an alert. Like, I'm excited about all of that from a consumer perspective. So the fact that you're excited about it from a diagnostic and a clinician perspective gives me some hope in spite of a lot of things that are changing on the guidelines front right now. I wanted to ask you about, do you get involved in bone scans?
Yeah. DEXA scans.
DEXA scans.
Yeah.
And, so I was talking about this actually with a previous guest who is a dietitian. And to me, it's crazy that I guess the guideline is that women get their first bone scan typically at 65. And it drives me insane because I feel like the horse is already out of the barn at that point in terms of how much your bone density as a woman has decreased. I mean, what are your thoughts on this?
Yeah, I think it's challenging. A lot of the DEXA scans and the data around them are based on kind of age matched controls, right? So some of it is, it's really a statistical analysis, right? We do an image that assesses the bone density, typically of your hip, or femur, sometimes your lumbar spine. Sometimes we use the wrist if we need to, but it's based on sort of a statistical comparison to age matched controls. So some of that is because that's the age group that we have a lot of that data in, and because the bone density in women declines so much in menopause, right, which is typically in your early 50s. So that's part of why, and I think that it's there's a tension between sort of wanting information and just baseline prevention, right? So really, my view is that rather than screening you at 45, we should be making sure you're lifting weights, you're getting enough vitamin D, getting enough calcium, eating calcium-rich foods, those kinds of things. Super important for your bone health. That we should be screening for family history. Do you have family members who have suffered from frailty, from osteoporosis? Have you had fractures? I mean, certainly if you have what we call a fragility fracture or an insufficiency fracture, which is basically a fracture of like your hip, femur, or wrist, that without significant trauma. I mean, if you fall off a cliff and break your wrist when you're 50 years old, well, you fell off a cliff. That's probably why you broke your wrist. But if
hopefully that's all you break when you fall off a cliff.
Correct. But if you bang your wrist on the doorknob and you break it, well, your bone shouldn't break in that setting. But I think it's important that we're not just relying on screening, we're relying on preventative healthy measures, right? And we should be adopting those early in our life. And I'm all over my daughter and my nieces about this, that, your bone density peaks much earlier than you think it does, like in your 20s, right?
When I found that out, I was like, wait, what? And I did not take good care of myself in my 20s. I was working on Wall Street, and I was having a good time and working hard, and physical fitness was not at the top of my priorities.
Well, you've made up for it with endurance sports, I know. But
yeah, and I do a lot. I've done a lot of strength training since I turned 40, but still.
But it's never too early. Like,
that's the thing.
A message we should be getting out to our daughters and sisters and aunts. Like, You should be doing strength training early on, but even weight-bearing exercise, walking, lifting, even just body weight,
Mhm.
planks and push-ups and those kinds of things. Like you should be doing that early, and you should be thinking about your nutrition as well. And so I think that's a really important piece. Smoking, not good for your bone density, not really good for your cancer risk. Any of those things, right? So getting those messages out, I think, is really important as well. That I think it's important that we don't only rely on things like screening.
I think that's a great message. I didn't think of it like that, but I mean, I do tell people, right, for, accountability. I'm like, hey, there needs to be the resistance training, and even if it's body weight and even if it's doing push-ups off a wall, just
Right.
start there, right?
Right. And I would add to that, if you do get a DEXA scan and it shows, they get scored normal bone mass, low bone mass, which we call osteopenia, meaning like less bone than you should have, or osteoporosis, which is like you're really at an increased risk. And then they also often report what's called a FRAX score, which is related to your risk of having a fracture over time. And but if you were to have a bone DEXA scan and it said you had low bone mass, if you're under 65 and you haven't had a fracture, the recommendation would still just be that to increase your activity, start lifting, watch your nutrition, those kinds of things, because the medications that are available, most of which are in the category called bisphosphonates for osteoporosis, come with risks as well. And so it wouldn't change what you're supposed to do. So that's one of the things. That's the age group of 65 or 60 to 65 is when we would start treating for osteoporosis, because there the benefits start to outweigh the risks. So that's another piece of it. The other thing that women in their 40s need, and I'm not the expert here as well, but it's worth talking about hormone replacement.
Yes.
And
Yes.
that contributes, that can help with bone health. It's a conversation that needs to be had with a physician that has training in menopause. And there's a risk benefit consideration based on your own personal family history, risk factors, those kinds of things. But the thinking has really shifted around hormone replacement therapy, about the timing of it, and the risks that we thought were really scary about it related to blood clots and stroke are less than we thought if you start it in an appropriate time frame. Again, I'm not the expert on this, but I would say that that's linked to this conversation also about bone density.
Yeah, we have a couple of upcoming conversations with OBGYNs, and we're going to get into all of that because it's really important, and the different types of estrogen available, whether,
Right.
there's the patch, there's the pills, there's like the inserts, there's pellets, there's all the things. So, and I think that every day it seems like more information is coming out, and obviously it has to be, peer reviewed stuff, because there's a lot of also shysters out there.
For sure.
But around how, if you've had breast cancer, and again, we'll talk about that in a later episode about breast cancer, but that there are certain forms of MHT that can work for you if you've had breast cancer. And then, of course, there was that debunked study from, I think, 2000 or 2002 that everyone is still trying to recover from. So I appreciate you bringing that part of it up, because it is all connected. That's the thing with, I have 3 autoimmune diseases, and I got diagnosed in 96, 97 when no one talked about autoimmune, and the
Right.
internet was very nascent. And so you couldn't just like Google anything or
Right.
even Yahoo anything, dating ourselves. But what I learned at that point is that you have to quarterback your own healthcare. And that's
Yes.
where I think that upside with the transparency and the data is that no one's going to care more about my health than me. Like, you're a friend, and, you're going to try and help me if I come to you with a question and everything like that. But no one is going to look out for me like me.
Absolutely.
And
Absolutely.
so getting that data and being able to at least go to my doctor, and this is what I tell a lot of my clients, like, you have to go in ready to party when you go to
Right.
see your doctor. You have to have your list of questions ready. And I give them all sorts of strategies to prepare for that conversation, because they got like 15 minutes with you.
Right.
And they're going to go through their rubric of stuff, and you're going to blink and you're going to be done.
Right. It's funny. I just had this conversation with a family member who had to go in to the doctor, and I was like, "Did you tell them about this, this, and this?" And they were, "Oh, well, no, because I figured that that was separate." I was like, "No, you have to go in and tell all the things. Right?
Yeah,
You have to
yeah,
write them down, and you have to say all of them, because they also don't know, and they have a list of questions, but they don't know what you're thinking, what other symptoms you might have that could be related. And even if you don't think they're connected, they might be able to connect them for you or determine that they're not related. And you have to share all of that. I wanted to add one thing about DEXA scanning and bone density, just because this is kind of related to what we were talking about earlier about opportunistic screening, things like AI, sort of new developments in the radiology world. And so DEXA scanning is considered the gold standard around bone density. And again, sometimes we have to do it in kids who have, like if you have Crohn's disease or some autoimmune diseases, you can be at risk for lower bone density. And we do it in younger patients, but the data is not as good because we don't have as many age-matched controls. But nonetheless, it's the gold standard. But we can obtain bone density information from routine CT scans. And now that's not to say you should have a CT scan for that purpose, because DEXA scanning is much easier than a CT scan. But many people have CT scans for other reasons. And actually, it's easy to obtain a bone density measurement from your lumbar spine from the CT scan. And again, there's not as much data around that, but we are able to make some assessments about that. So, if it's something you're concerned about, it's an area where you could, if you had a CT scan, you could inquire, was a density measurement taken on my spine? That's something I think there's a lot of people in the orthopedics world who are, and in the radiologist space, who are advocating for that's something that we start to incorporate more routinely into reporting, where it's from the lumbar spine, and we can take a measurement of the density there. And that, again, in sort of envisioning what the radiology report of the future might include, it might include a whole section on preventative data that can be pulled, that's based on like how much body fat you have within your peritoneum, not in your, which means like inside your abdomen where your organs are versus within just under the skin. We can make risk assessments based on that, how much calcification you have around your aorta, things like that. And bone density is one of those. And those aren't things that we might report them, but we don't traditionally link them up with your risk and your preventative strategies. But I think that's where the future is going.
I think that's really insightful. And the reason why I'm saying that is that, one of my biggest fears, and I was very careful with my latest hip replacement, was that I didn't want to develop a back problem. Because it seems like once you get a back problem, you have back problems, right? That's at least what I've seen with people. Like you just have a bulky back. And so, knock wood, I'm not one of those people. But I know enough people where it's like they get, MRIs and CT scans of their back, but I wonder if they've ever thought to be like, oh, hey, let's like look at the bone density as opposed to seeing like, oh, do I have a herniated disc or something?
Right. Interesting. Yeah. I mean, MRI is not the place to get a bone density measurement, but CT scan. But this is a whole other area we could talk about.
Oh gosh, we can bring you back. We can bring you back as much as you want, Rachel.
About spine imaging, because and I think this makes an important point that's maybe good to kind of finish up with, because I think it's the instinct to get as much data as possible. I fully understand, and it's sort of my inclination as a radiologist. I think we have so much data we can use that we can give to people, but you have to balance that with living your life and not just creating a ton of anxiety for yourself, right? We could find, you can go out and pay a lot of money and have a whole body MRI scan. And yes, you might pick something up, super early that may or may not turn into anything. You can also lead yourself down a path of fear and anxiety and endless testing, and you have to be a little careful about that. And spine imaging is a place where people come in with pain. Most disc-related pain gets better over time. Often we see things in the spine. Some spines I look at, they look horrible. I think, oh my God, how's that person walking? And that person has very little pain. And other spines on an MRI, and there's evidence around this. Other spines look pretty good, except for one little thing, which is not on the side of the patient's pain, and the patient has terrible pain. And MRI of the spine is an area in particular where it's very hard to correlate what we see with what the patient is experiencing, and can nonetheless lead to surgeries and all sorts of things. So it's important information can be very helpful, but it can also just confound the picture.
Yeah. I should send you the link. I interviewed a doctor she used to be a practicing pediatrician, and now she does pain reprocessing therapy. You'd probably find it interesting, so I'll have to send that to you. All right, we're going to wrap things up here.
Okay.
And first thing I want to also mention that I didn't mention at the top of the show, that none of this constitutes medical advice. This is not a patient-provider relationship. This is just information for you to discuss with your healthcare provider. So I just want to make sure that we make that emphatically clear for everybody. So, Rachel, if people wanted to find you, do you post anything on social about radiology, or do you kind of just keep it about your personal stuff?
I post on LinkedIn a little bit about health innovation, health tech, AI and radiology, sustainability in medical imaging. So most of my posting would be on LinkedIn around.
All right, we will link to your LinkedIn account there. I want to thank you for taking the time, and I can't wait to have you back. And I guess we're going to have another episode on back pain. So
I got all these topics I wrote down. We haven't even got to.
All right, well then we're gonna talk about it. But I want to thank you for your time, your generosity, really breaking things down and shedding some light on some really current topics that people are concerned about, particularly women today.
Yep.
And just
thank
want
you
to
for inviting me.
Of course.
That's a treat.
And for everyone else, thank you for taking the time to listen. This is Going the Distance with Go Long. I am Jill Consor Beck. Again, we provide accountability coaching via text. Go to golong.me, learn all about it. Remember, it's your life. Go the distance. Go long.